Good evening, everyone, and welcome to the Medical Society of Delaware's 236th annual meeting. I'm Steve Kushner, a past president of the Medical Society of Delaware and chair of the Education Program Planning Subcommittee. Our session theme is The Body Connected, Healthcare Wearables. Tonight, we'll explore how wearable technology is transforming modern medicine and the way clinicians engage with patients. We'll begin with a keynote presentation from Martha Hall, PhD, who will share insights into how wearable innovations are advancing patient care. Following her presentation, a multidisciplinary panel featuring experts in cardiology, endocrinology, sleep medicine, and legal counsel will discuss the wearables recommended to patients, their clinical applications, and important legal considerations that come with integrating these technologies into practice. It's now my pleasure to introduce our keynote speaker, Martha Hall, PhD, a designer, engineer, biomechanist, and scientist focused on creating wearables that improve quality of life. She defines wearables as clothing, devices, or embedded technology that improves patient health outcomes while also being practical, comfortable, easy to use, and aesthetically pleasing for the user. She is a University of Delaware alum, as well as a director of innovation for the newly founded Institute for Engineering-Driven Health in the College of Engineering at UD. She holds 55 patents in wearable technology through the University of Delaware, with the goal of translating her products to the hands of the patients she is trying to help. She lives in Chester County, Pennsylvania, with her husband and 4 dogs. We welcome Professor Hall.
Thank you so much for that wonderful introduction. And let's see. I'm happy to be with you all today. And so thank you for giving me this opportunity to talk about an interdisciplinary approach to looking at wearables and health applications. So I will just launch into my presentation, which is about empathetic design, fashioning improved health for individuals with disabilities. And I am the Director of Innovation for the College of Engineering at the University of Delaware. I'm also an assistant professor in the areas of biomechanics, electrical and computer engineering, mechanical engineering, fashion and apparel studies, entrepreneurship under the University of Delaware, and have my own company that is focused on translating the research that I'm doing at the university into, again, the hands of the people I'm trying to help. So I wanted to give you a little bit of background about who I am and the approach that I have to this space. I am looking at research from the perspective of how do we create devices, whether those are rehabilitative devices, whether those are patient health monitoring devices, whether those are, orthopedic devices to help a patient post-surgery. How do we look at those devices from a sense of improving health outcomes, from a sense of the patient driving that process and the patient driving the expertise? So what that is able to do is to have a space where we're able to talk about patient compliance, patient adherence, and things that are practical for people to use in their everyday life. What you're seeing on the screen is just a smattering of the different organizations that I've worked for to help talk about this opportunity from an interdisciplinary perspective, whether that's looking at healthcare organizations with Christianacare, Nemours, or looking at different apparel companies who want to help create opportunities for mobility and improved quality of life. Or even I have worked with sports organizations in the Philadelphia area, again, with the understanding of how can we create these post-surgical or post-ortho devices where the individual feels like they have ownership over the device design. There's a co-creation aspect, but there's also an opportunity to create improved healthcare outcomes because of that co-creation. So I wanted to talk a little bit about how I got started because my background is a little bit unusual in that I am a fashion designer who got her PhD in biomechanics and electrical engineering under the mentorship of a physical therapist in pediatrics. So that in and of itself is a little bit of a challenge to, share how that interdisciplinary aspect to this idea of health wearables can be advantageous, can be a value add. So I was looking at, from being a fashion person, I had initially thought about myself of going to New York, doing ready to wear, creating things for women's wear, in the very kind of cliched way that you would think of that. So having an opportunity to work with another fashion designer or have my own line. But instead, I decided to go back to school and see if I could create something using my skill set as an apparel designer to help improve quality of life. Is there a way that, although, cocktail dresses are lovely and impactful to some extent, can I use this skill set to really be more meaningful? And so I went back to school and had the opportunity to look at how can we create devices that are not only functional, but are also expressive and embodied that difference that previously we may want to be more discreet about, but there's an opportunity to be more expressive. So what you're seeing on the screen is I was asked as a master's student to how can we create an alignment between fashion and health. And at the time there was a exhibition at New York City and the Metropolitan Costume Exhibition of Alexander McQueen. And Alexander McQueen is was a very avant-garde designer. And I looked at this garment of what looked like a leather bodice and a lace skirt and leather boots as a very on-trend ensemble. But as I saw the model in the middle walking, I noticed that these weren't leather boots that she was wearing. These were prosthetics. And what I thought were leather boots were actually her prosthetic legs. And so this is a model, Amy Mullins, and she was born a double amputee and was a model for Alexander McQueen for this exhibition. And it highlighted not only was someone not trying to disguise an embodied difference, but it was trying to highlight an embodied difference. And that really excited me. And concurrent with that, I had the opportunity to work with a professor who has since retired from the University of Delaware, Cole Galloway. And Cole was working on lower extremity devices for infants and toddlers that had mobility challenges, developmental delays, and was advocating the fact that here are these kids who can't be mobile and have to wait for a certain amount of time for them to have mobility devices, usually by the age of 5. And once they got that mobility device, it was this kind of bulky, hulking device of a power chair that was intimidating, often caused stigma with their peers. And he was, shaking up that model with saying, why can't we have lower extremity devices for kids that are more fun and more socially engaging and more family friendly and more, cost effective. And so he was going to, at the time, going to Toys R Us and taking these ride-on cars, whether they were like Barbie cars or Steve, like Lightning McQueen cars from the movie Cars, these different little toys that kids would have to run around, and he would take them, put PVC piping, reconfigure the electronics to have them be essentially wheelchairs for kids who had lower extremity challenges. And that was a game changer for me. He was advocating this idea of, you know, these devices can be much more engaging to kids who want to use, engaging to their peers who want to quote unquote play with your wheelchair because they want to turn on it, be more cost effective. At the end of his talk, he talked about, we can even do this with upper extremity. We can do with clothing. We can have opportunities with creating clothes that helps kids move and play. And I was so engaged with his conversation or his talk that I went up to him and said, I have a fashion background. I would love to volunteer. And that very quickly precipitated me being a part of his lab and having a PhD in biomechanics and movement science at UD under his mentorship. And so my education was very vast and dynamic within the university. And I was very grateful for having these different opportunities to come to a program that was very much stemmed in kinesiology, PT, OT, and someone who is a fashion and apparel studies major. That was a little different for a lot of my professors to engage with, but they got that I had a toolbox that I could bring to the table with creating these devices, with creating something that may be more practical, more comfortable, more or less stigmatizing for the individual. And that really became an opening gambit, so to speak, with engaging in this space in research and technology and wearables. Prior to that, there's a gap for me between my undergraduate and my graduate work, and I had done some work in apparel design and functional design, and specifically in children's wear. So had a understanding of customer need, what people were excited about, what people would like the fit of different wearables, which is a extremely important point in having that patient compliance and adherence at the end of the day. So I wanted to, before I get into my particular process that I adopt with developing new wearables for health related applications, I wanted to give you some examples of things I've done to date and the different patents that I've pursued. So one is MAMA. So MAMA is an acronym for Midline Alignment Medical Apparatus. And I should say that the lab that I've been working with for the past 6 years is very much integrated with undergraduate and graduate student research. And adopting, which I will unpack a little bit later, but adopting this need-driven or user-centered approach to wearables design. So the MAMA project was brought to me from a student who I was working with who was interested in nursing, had noticed that the babies in the NICU that she was shadowing didn't have opportunities for kangaroo care or skin-to-skin contact with a caregiver. And skin-to-skin contact is essential for newborns to, especially preterm babies, to develop the ability to breathing, body temperature regulation, heartbeat regulation, also being able to latch on for caregivers with milk and feeding. And so looking at what was happening in this case with the Christiana Care NICU, we had a great opportunity to shadow several of the NICU nurses, and with Dr. Paul, who was the director of the NICU at Christiana Care, being able to see that a lot of these babies who were born preterm didn't have access to kangaroo care, didn't have access to skin to skin contact because of the babies being so medically fragile and the different, challenges they faced. And so this project is developing essentially a simulation of what it would be like to lay on, in this case, a mother. So having a bed that has a silicone interface that resembles a female torso, and it breathes, and it has a heartbeat, and it also can simulate the caregiver's scent to help with feeding. So this has been an exciting project that we've done in collaboration with Dr. Paul. Another example is looking at opportunities for hydration sensors. So this was another thing that wasn't on my radar, but brought to me from FEMA, which is active duty firefighters often are challenged with being dehydrated, and especially when they're in active duty scenarios. And so we collaborated with FEMA based in Kansas City, looking at how can we create hydration sensors that are based in the firefighter's uniform that can monitor their hydration levels from a locality, also monitor where they are in space as far as where they are in the building. And this has other applications beyond this particular population. For example, looking at patients who are in memory care who have Alzheimer's and may be challenged with being reminded to drink water and being hydrated. So this had a life beyond just the initial population of the firefighters, and looking into people who suffer from Alzheimer's and perhaps are in memory care. The M2 band is another project that we developed with collaboration from our local community. So a professor who was working with adults with intellectual disabilities, specifically physical fitness tracking, and how do you motivate people in this particular population, the values of fitness, the values of exercise. And so we gamified that wearable. And so these are shoelaces which attach to any shoe and can light up as the individual is reaching their fitness goals. So essentially creating a game where there's an engagement with trying to get to a certain level with their fitness. And ultimately, our next step is having GPS. So, understanding where people are, if there's an opportunity for people who are maybe in more vulnerable populations, whether those are people with cognitive challenges, having the opportunity to not only, track fitness and track activity, but track location. Another example of wearables that we've worked on is a high ankle sprain brace. So this was brought to me from the UD athletics community. There was a need for, in this case, football players who had sustained a high ankle sprain injury. And to date, there hasn't been a appropriate device that's commercially available to help athletes who sustain a particular, what's called a high ankle sprain. And once they've had surgery to help, get them onto the field, get them into playing in a safe and structured manner. And so we're able to show that using 3D printing technology, scanning the players, getting an understanding of their anthropometric data, and facilitating their healing post-surgery, that we're able to return them to play 25% faster than the standard of care. Another example, similarly in athletics, is I was lucky enough to be tasked by the Philadelphia 76ers to create a protective face mask for one of their players. So, gosh, 6 or 7 years ago at this point, Joel Embiid, who's their center forward, had sustained an occipital bone injury. And typically, when players have injuries to the face, there's kind of a one size fits all kind of mask that's available to help protect them as they're recovering and healing from surgery or from injury. However, most professional athletes tend to be larger, and so there was a challenge around fit with this particular face mask. There's also a challenge with like sweat accumulating, fogging up, uh, lack of visibility. So I was able to meet with the player himself and get an understanding of what his needs were, and taking a 3D body scan of his face and creating a carbon-based fiber polymer mask for him that had a reactive fluid retention system to help kind of contract on demand and also be aesthetically pleasing. So at the time, and this kind of dates this project, but at the time, the Marvel movie Black Panther was very big, and he wanted to have something that was reminiscent of the Black Panther Marvel mask. So we were able to do that. And that created something that was above and beyond what was the general standard of care for basketball players at this time, and allowed him to feel comfortable, heal quicker, and get him back into the game before he would obviously do that. Oh, another example, kind of shifting gears, is looking at wearables that don't necessarily augment injury, post injury or post surgery. The knitted Kevlar project is a project where we were looking at creating a augmented textile that could provide ballistic protection beyond what's currently available. So how do you create a textile that can go beyond what's currently the ballistic protection for police or military? Right now, police and military wear protection just for their torso. That is heavy and is often 10 to 20 layers of fabric, in addition to ceramic plates that kind of help with both knife stabbing and ammunition. And so we were able to create something that was knit, so it had the same kind of feel as a t-shirt or a hoodie as far as the stretch that it offered, and yet still provide the ballistic protection that is needed for these type of active duty scenarios. And we've now advanced this technology to engage with canine protection. So looking at police and military canine duty uh, animals who don't have any kind of protection as they are right now, but we can create essentially a bulletproof dog sweater so that they have the opportunity to be safe and to engage in the active duty that they need to do, and also be able to repel the different attacks that could potentially be possible. And addition to that, so we've talked about different rehab and ortho opportunities, some textile and electronics, but there's also wearables related to quality of life and looking at people who aren't typically covered in the apparel industry, the medical design industry. And so from a fashion perspective, the customer is often characterized as a typical bodied, fit adult between X and Y size. And so if you fall outside of those parameters, it's often challenging to find clothing that fits you. And so one of the other things that's a passion project of mine is what I call outlier markets. So looking at people who use power mobility or are seated users, or people who are on the gender spectrum and are looking to do gender presentation with their clothing. There's opportunities for creating wearables that help people be mobile, help people feel comfortable presenting themselves as they want to be presented to others, which isn't currently being addressed within the market. And so looking at opportunities within the wearables market, there's a few examples that I just wanted to highlight. So one of the exciting ones is Levi's and Google. So there's an opportunity for wearable technology in clothing. And I would say this is more kind of in the novelty space, but looking at how we can create clothing that has the same kind of functionality that we get with our phones. So Levi's and Google collaborated on a trucker jacket, which as you brush your sleeve, you can, you know, bring the volume up, bring the volume down, zoom in, zoom out. So they're looking at tactile inputs to mimic what's going on with phones. Similarly, we have a company called Sensoria. So Sensoria Health is even taking that one step further, which is addressing the holy grail, so to speak, for wearables, which is washability, being able to have a customer use a wearable electronic in a way that they can take care of it. And so Sensoria has a sock that can monitor gait, balance, even heat mapping, and do it in a way that interfaces with your phone, but also allows you to have the silicone embedded traces so that you can wash this, which is huge. There's another company called NADA, which is looking at similar types of integration using inertial measurement units, or IMUs, to identify the body in space. So to map body angles, joint angles, orientation, in order to have someone understand, from a consumer's perspective, to understand kind of how their body alignment aligns with the proper posture, but from a PT/OT perspective, gives them the benefit of a specific therapy, which is also really exciting. So if you think about how we can move forward with, okay, so I'm interested in an augmented wearable, I'm interested in an instrumented wearable, kind of where do you go from that? The history of this is we are at a place where, a few decades ago, we had very bulky components, and those are being more and more streamlined as we go. And so the interface between the person and the wearable is much more comfortable and much more synergistic than it's been in the past. And from a commercial perspective, there's a focus on wearables kind of falling into this wrist area, or even augmented with eyeglasses. And that's kind of where we've paused from a design perspective is, we have an easy area from a biomechanical perspective. We have an easy area with the wrist to, do something similar to an Apple Watch or a Fitbit. But as I will kind of share and what I've already shared so far, is that you can go beyond just having something that's located on the wrist. You can have something that's much more integrated to create that data collection that's much more meaningful, specific to the intervention that you're trying to um, collect data from. So that brings us back to, how can we merge these disparate areas? So looking at fashion, electronics, biomechanics, health sciences, there's exciting opportunities in this divergent space, which is looking at conductive materials, different ways of creating sensors that are much more engaging to patients, much more comfortable, much more easy to take care of, and less bulky than just having something electronic built into their clothing. And there's many different communities that are emerging in this space. So Becky Stern at Adafruit, Leah Buckley at LilyPad, there's this whole idea of textile-based electronics that are meant to be integrated into clothing and fabric so that it's much easier for the end user to take care of it, and much less weight and bulk versus wearable electronics. So if you think on the left of building a circuit to have a light, if you look at the right, you can have the same kind of circuit that's much simpler and much more integrated into fabric. Similarly, you can do whatever you need to do as far as working in series or parallel, um, whatever outcome you're trying to achieve, whether that's incremental or holistic. You can do that with conductive materials as well. There's also an opportunity to do that with printable films that are getting more and more discreet and easier to engage with textiles. Similarly, if you look at a potentiometer that's available off the shelf, you can have these essentially a switch that's available that can be integrated into your wearable, but you also can do that on the right with metal connecting to stainless steel embroidery. So again, it's just highlighting that fact that you can create wearables that are much more integrated into the clothing. And these materials are easy to use. For any of you who have any sewing experience, this is a bobbin. You can put it into your sewing machine. It's stainless steel or potentially silver coated, whether it's 1, 2, 3 ply, so the thickness of that thread, but it can be put into a sewing machine so that it can enact the circuit and essentially print the circuit through stitches that you would do otherwise. There's also fabrics that can do something similar. So looking at woven material, knit material of different fiber contents, whether that's silver or copper. You can have conductive Velcro that creates a switch so that binary off-on can be done through Velcro. All of these are readily available. So if you're interested in creating these wearables, all of this stuff is at your disposal to kind of experiment with. Similarly, there's opportunities for printing. So if you have the ability to print onto fabric, creating your trace, using tape or ink that can do that. That's another workaround for the stitching that we highlighted earlier. So you've got a idea of how to measure movement, measure patient health outcomes. So how do you actually apply that to the body? So essentially you have to create a garment that can register uh, the data that you're trying to collect. And so in a super general aspect, there's 3 different ways of creating clothing that in the relationship it has to the body. So on the left of your screen, there's positive ease. So this is a garment that has space between where your body ends and where the garment starts. You also have in the middle what's called perfect ease. So having a garment that mimics the body lines perfectly, so there's no gap between where the body stops and where the fabric starts. And then you have what's called compressive ease or negative ease, what you're seeing on the right, which is a garment that is smaller than the body, which expands once it's worn by the individual. And so this is often a huge challenge with people designing and developing health wearables, is understanding what the sensing component needs to be in relationship to the body. And so we typically think about it within perfect ease or negative ease. So having a garment that either fits the body exactly, or which is a little bit easier, is having a fit that is smaller than the body because there's a knit construction, and so it allows for that expansion and contraction. And so when you think about what your ultimate goals are, what your outcomes are with what you're trying to achieve with your wearable, there's a balance between the functionality of said wearable and the person or patient population who is going to give you your data collection, and being mindful that yes, there is a metric that you're trying to achieve from your functionality. So you want to make sure that yes, it works. You have reliable data, that you have data that's not going to be corrupted based on different environments. But you also have a person who needs, in order to wear whatever wearable you're trying to devise, they need something that is easy to use, that is comfortable to them, and that they can take care of without an onerous amount of instructions. And so that's kind of the conundrum I think a lot of health related wearables fall into, is this historically a disconnect between engineers or scientists who want said data and the reality of a person wearing your data collection mechanism, and what they're willing to put up with, and what they're willing to tolerate, and having that co-creation and that understanding of where those opportunities overlap, I think is really key, and a opportunity that a lot of current mechanisms don't address. So from my perspective, a lot of what I instill in my students is trying to engage with an opportunity of health related wearables and how we can take those to market in a way that's meaningful, novel, disruptive, dynamic. And so that often falls within students having an entrepreneurial mindset. And an entrepreneurial mindset is not necessarily like, okay, I want to start a company. It's more about being open to, like, having a strong vision, being open to having mistakes, failing forward, um, being excited to learn things that they don't already know, um, having a team mindset. So all of the things on the screen is central to realizing that in order to create these type of products that are going to essentially help um, move biopharma forward, or move ortho companies forward, or move wearable tech companies forward, is embracing these different areas and understanding that it's okay, to um, focus on these different things, and to know that you don't necessarily know all things about everything, and that collaborating with a team and knowing who to um, task to is super important in order to get the objective done. And so I have adopted with my students a user-centered design process that is based in Stanford in the D School. And they talk about a empathy-driven or user-centered process. So typically from a designer perspective, we come with a problem, brainstorming, test something, create something, test something. But what's exciting about this process is realizing at the beginning that you aren't the expert, and that there's someone who has a lived experience that is just as important, if not more important, than your expertise, whatever tool set. So whenever I go into a project with different patient populations, I cannot um assume anything about a patient's lived experience, but as much as I can immerse myself into where they're coming from, um, what their challenges are day to day, that only helps me as a designer get to an end result that's going to be more meaningful, more impactful, more useful for both them and a broader kind of health organization perspective than anything I can come up with as a designer who thinks, okay, like, I know X or Y. And so where I start uh, with these populations is trying to get to as close as I can with where are they coming from and what are their challenges. So um, my design process is patient agnostic, meaning I'm a designer. I'm not a researcher stemmed in any particular patient population. So when when a patient population, or a healthcare organization or nonprofit brings something to my attention as a particular problem, I need to understand these different things. So I need to understand who my customer is, or who my client is. Um, that may be the person using the device. That could be the person who is purchasing the device. So, and part of that comes from my background with working with children. It's, there's an end user with that child, but that's mediated by the parent. And for specific patient populations, that could be mediated by a caregiver. So ultimately, who am I serving? Where are they? And so that meaning, where are they in the community? And one of the things my advisor Cole with Go Baby Go that I was talking about before, um, you know, making sure that you go to where people are, that you're not bringing people to where you are. And so meeting them where they are creates a comfort level, and understanding, like, are they more isolated in their homes? Are they visiting a community center or a group? Making sure that you're being active to meeting people where they are. What do you think is checking your biases at the door. So even if I've met with or worked with a particular group before or worked a particular population before, times change, research change, you know, innovation, interventions change. So making sure that I'm not assuming that I'm the expert in the room and being mindful of leaving that and being open to what I'm hearing as problem. And then what is the SOC is what's the standard of care? Like what's the current solution that I'm trying to address or trying to improve upon? And so that speaks to customer discovery from an entrepreneurial language is like getting at talking to people and understanding what their challenges are day to day and having that engagement on a one-on-one level so that you're really getting a depth and breadth of the problem. And so we do that with looking at surveys, looking at interviews, looking at focus groups, and then collecting that data and doing analytics so that we can kind of drill down to what we're hearing. And ultimately that leads us to define the design problem, so to speak. So if you look at all of the conversational data that you're getting from people, drilling down into what are the pain points. So what are people telling you their problems are? The barriers, what's keeping this problem to already being solved? Alternative solutions are what are they doing now to mitigate those problems? And feasibility is what is the cost, time, technology gaps that we face in order to address the problem as stated. And then we also, from a wearables perspective, need to think about the different aspects of what wearables include. And so, first and foremost, and I think a lot of what we think of medical, health-related wearables, we think about improving function. So yes, that's a huge metric that we need to address. But there's also other pieces to, a visual presentation of self that people are on the spectrum of having engagement around, and it's important to at least be aware of those. So one is aesthetic. So the wearable needs to be aesthetically appealing in some way, shape, or form to that person that you're trying to have adopt that wearable. So they need to feel like, okay, this seems based on what I'm looking at, I'm comfortable wearing it. I think it might work. Like it doesn't look janky. It doesn't look half baked, so to speak. So having something that addresses a appealingness spectrum is important. Expressiveness means that someone will be more apt to be compliant and adhere to adopting a wearable if they feel it aligns with their identity. So if you create something that is super bulky or super divergent from typical clothing, if you have someone in, I'm saying this as a extreme for the point of conversation. If you have someone don like a Iron Man kind of exoskeleton versus something that's discreet and part of their long t-shirt or pants, if you have something that's beyond what someone's comfortable wearing, as even if it's functionally advantageous, the adherence and compliance will be less because it doesn't align with that person's sense of self. They feel awkward or stigmatized by wearing that. And then lastly, the accessibility. Whatever the wearable is, it needs to be something that is affordable for the client or the customer or the target market that you're engaged with. It needs to be available to them. And so all of these pieces are on the spectrum. People care more and less, but it's opportune to acknowledge that these metrics are important so that you have the engagement that you're hoping to have with your patient population. And so once you've kind of galvanized your idea and your concept, often designers talk about brainstorming and prototyping separately, but I adhere to a ideation and rapid prototyping matrix in which you are building what I would call a low fidelity prototype. You're getting input from your patient population. You then can go back to the drawing board and revisit it. And you're doing that as many times as you need. Otherwise, you're elongating the production and take to market or clinical trial application as you're figuring out what people will or won't wear or will or won't work or the technology. So having those things combined allows you to more efficiently get to the end goal ultimately, which is to have a wearable that's meaningful. So for me, it was creating an exoskeleton for infants and toddlers, which was brought to my attention from Cole Galloway, who I mentioned earlier, and Go Baby Go, and looking at how do you create a upper extremity device that can help a child move and play and feed and keep up with their peers in a developmental way. And so what you're seeing on the left is a child who has arthrogryposis, which is a presentation of upper extremity weakness and fatigue. And so this is a child who's neurotypical, challenged with, how do they engage with their peers and engage with their environment, engage with toys, engage with food. And so creating a device that helped lift their arms against gravity and let them do those tasks. And then what I learned through the iterative process and the process I've outlined is creating something that's much more child friendly. And so looking at clothing that can be easily washed by the parent and maybe expressive, so it feels more like a princess dress and it has the big tutu skirt, making it so it looks like a Spider-Man costume. That helps the engagement with that child to want to wear that garment, have it be a tool for development, and ultimately get them to their PT goals. And so this is an example of the kids I was just talking about. So this is a little girl who has the diagnosis I just talked about, challenges with upper extremity, wanting to engage with a toy, but not necessarily able to do that. And the typical solution for that was to create a device that had a static brace with a wheelchair and having these Velcro straps. And so, what we were looking at for infants and toddlers was something that was similar. And as any of you who have 3 to 6 month old babies or have experienced that, trying to strap on an exoskeleton for these babies was very challenging, and they didn't want to comply with that, and very quickly understanding that it's not about patient compliance. Like, this baby was wearing the standard device that the practitioner was applying for them, but it wasn't in line with what would be useful and practical from the point of a infant and toddler. So we created something, as you saw earlier, which was, how do you create a device that had the flexibility and the instrument of the exoskeleton, but had it embedded in a onesie, which was much more practical, much more useful, much easier to care for, had the same dynamic, but was much more family friendly than the kind of struts that you saw with the exoskeletal. So, given the time, I want to make sure that there's a little bit of time for Q&A. So I hope this was meaningful, helpful as far as kind of looking at wearables from a patient-centric perspective and different ways to engage from, an outside interdisciplinary perspective. But I so appreciate the opportunity to talk to you all, and I will open it up to questions.
Professor Hall, thank you so much for that very insightful and inspiring presentation. Your work truly highlights how wearable technology is transforming patient care. And we'd like to now open the floor for questions. And Lynn, if you'll help me with those.
Sure thing. We have some questions in the chat. Can you please comment on potential risks for injury from wearable electronics in context of high amperage electric discharge, such as industrial settings, lighting, etc.?
Yep. So yeah, there's a whole kind of host of specifications with ASTM and FDA clearance devices with making sure these things are safe. And so it's important that, as a clinician, if you're interested in, creating a new device or creating a new intervention for your patients, to be mindful of the risks, the safety hazards. There's a lot of unknowns around, especially when you create things that have electrical stimulation, vibration, anything that has to do with a mechanical impact to the body. But as time goes on, we're getting a little bit more direction around guidelines and standards. So just being mindful of the ones that already exist. And I would even say being proactive to anticipating what might come along the path for the things you're working on. So for example, I'm working on a device right now that has stim for neuropathy, and there's not a lot of guidance so far from a federal mandate, but assuming that there will be milestones and hurdles to meet along that pathway, being conservative with what the FDA has done to date kind of helps make sure that the protocols and procedures that we're putting in place now are not going to be redundant or need to be revisited necessarily when the time comes.
Thank you. We have two more questions. Can you potentially monitor every body function with a wearable? And is there any danger of overexposure to the electronic injury?
So the question around what you can monitor, it's really a limitation of what the sensors that are available can do, and what you can extrapolate from what already exists. So what I mean by that is there's sensors that do pulse, heart rate, respiration, body temp. There's some off-the-shelf sensors that can kind of capture that data. There's also a lot of research in creating new types of sensors, and I'm limited from my knowledge into textile-based sensors. So looking at strain sensors, bend sensors, force data, different things that can measure orientation in space, that don't necessarily seem like they would from the outset, but that you can mathematically correlate to certain types of joint angles, for example. So I think the limitations are with kind of what people think is possible, and I think we can extrapolate quite a bit from what exists now. And as long as we can kind of track what we're trying to document, that's a good first step. But I mean, this space is exponentially developing, and what's possible is changing all the time. So what we can do now and what we can do 6 months from now is going to be really, really different. But a lot's possible.
Thank you. And our last question, is there any literature review that discusses the mental health cost, such as when certain wearables are being used, such as disordered eating with CGM?
Um, Off the top of my head, not that I'm aware of. I think that's a good white space to explore is, you what are we missing as far as the mental health? From a physiological perspective, it's challenging to have wearables that track, anxiety, that track depression, that track emotional regularity, all of that. I think that's a huge open ground for exploration that hasn't really been scientifically proven yet or explored too much yet. So as someone who that's top of mind, those different challenges are top of mind. I think it would be important to be mindful of the potential there. And if there is a physiological correlation that we can make, that a wearable can capture that data, that would be super exciting. And I hope there's more exploration in that space.
Thank you. I did see two more that came in quickly. Where could we get the shoelaces that light up? Dr. Perry's with the Rosa Health Center, and she has a special needs patient that those would be perfect for. So if we can, if you have ideas for that, we can connect you with Dr. Perry. And yes, and Dr. Henderson asked about cost and insurance coverage. So both of those, if
Yeah. So to the former, just reach out to me. I'm happy to to give you the designs that we've created and see if that's useful. That would be amazing. From an insurance cost perspective, I mean, this has all been through an academic research mechanism. So through internal university funding or NIH funding or NSF funding. So we haven't had the real world consequences of what does this look like with insurance, but I'm very interested in having that conversation. So if someone wants to kind of follow up with me, I think in order to translate this from the ivory tower of academia to the reality of patient engagement and the communities, I would love to try to ideate around that and see if there's an opportunity to tackle that. But so far, I haven't had to deal with those challenges, but I'm super aware that those exist, and so if there's a way of we can kind of continue the conversation around that, I'd be happy to do that.
Sure, we can certainly connect you. Any
Yeah.
insurance coverage on these wearables?
So again, all of my work has been through the university, so it's been through grant mechanisms. So I'm not really sure.
Okay. Thank you so much, Dr. Hall. I'll turn it back over to Dr. Kushner.
Very good. Thank you again, Martha. Truly insightful. All right. Well, we'll now continue the conversation with our multidisciplinary panel discussion, where we'll explore how these innovations are being used across specialties and what they mean for patient care. I'm your panel moderator and will lead this engaging discussion. Each member of our panel will have a 10-minute presentation followed by a full panel question and answer session at the end. Our first panelist is Lyron Deputy, a nurse practitioner with over 20 years of experience in sleep medicine. As founder of the Delaware Sleep Disorder Centers, he's led initiatives in sleep diagnostics, remote monitoring, and wearable technology aimed at improving patient outcomes and access to care. His work focuses on bridging traditional sleep medicine with the next generation of connected data-driven solutions to better understand and treat sleep disorders. Welcome, Lyron.
Thank you very much, Dr. Kushner, and thank you, Society, for allowing me to speak today. And Lynn, thank you for allowing me to follow Dr. Hall on that great presentation. I thank you guys. Next slide. I was fortunate that you guys allowed me to talk about this today. I think we all have seen these devices. Some of us are wearing them as we speak. And I think it's very important for us to understand a little bit about where this technology is going. So my first slide looks at the revolutionary points of these wearables, which obviously it's allowing people to be able to monitor their trends at home, which I think is important. They also give us valuable insights on looking at how we sleep. And I think that is definitely better understanding for them to understand when there's problems that are happening. It's good at trend detection and it's very convenient in many aspects. But again, as we talk through this presentation, there are some limitations in the accuracy of these devices. The importance of sleep tracking and patterns. As most of us know, if many of us can get enough sleep, it does impact our mental health, our metabolism, cardiovascular function, and also our immune response. I do apologize. Some of my slides, for some reason, I have a glitch in my PowerPoint, so there's some redundant words in there. I definitely tried my best to kind of get rid of it, but as you see in some of these slides, you'll see that. The one thing that's important about these wearables, it does not replace the traditional testing, which for the most part, polysomnography has been the gold standard. But as we also know, home sleep testing is also a standard that we use for predominant patients based upon insurance and other cost things. But ultimately, those are the ones that we prefer to basically diagnose conditions. But these wearables do fill a gap, which allows us to be able to really have those conversations where before it was very difficult to have it based on subjective data, but now it's giving us some objectivity to be able to discuss that. As I mentioned before, they're very accessible. So how do they work? Many of them look at motion. Accelerometers are little sensors that measure motion that capture movements aiding in sleep tracking. Photoplethysmography basically uses non-optical techniques to measure blood volume changes in the tiny vessels under our skin, which basically uses that to calculate heart rate variability for sleep analysis. Some of these sensors have temperature that measures that and respiratory efforts, which is important. Many of the advanced ones are actually coming out showing brain activity from EEG measuring, which basically gives us a more understanding of sleep and wake. And these devices have algorithms that really look at this information to kind of give us some of the metrics that we obviously look at. And again, a lot of these devices have different ways of that, and some of their scores are not always the same. So what does the sleep data really tell you? As we look at this, it does give us some sleep detection. And again, it all depends on the device. Many of these devices combine some of the sensors that I talked to you about, which aids in helping us detect sleep stage accuracy. But a lot of these are in different forms. There's wearables on your wrist, things on your finger. There are some devices that go around your head and some that attach to the skin. But again, they do not replicate accuracy as consistent as an in-lab or home sleep test. But again, having these devices at home does give us some detection over trends that allows us to be able to see if there's something going on. And as more and more of this data and these devices are coming out, even over previous models and versions, it is getting closer and closer to be more accurate. So how accurate are wearable devices? 95% of them, 95% sensitivity to sleep and wakefulness. Again, many of these look at movement. So obviously, if you're still, it determines that you're sleeping. Sometimes people may be awake during those times. The Oura Ring has been, in many research studies, the more accurate in detecting some of the sleep versus wakefulness, which ultimately because of their data and some of the sensors that are in their ring, and they've been around for a while, has allowed them to be able to really improve on that technology. Many of them have challenges, again, as we talked about, with wakefulness. And again, a lot of this varies between models and versions and some of the software that's involved in that. So would you rely on wearable data to guide a clinical decision? I always say it depends on the patient you're talking to, because sometimes they can be very adamant about the data that they may not understand. But again, some of the strengths enables sleep tracking in natural environments. It definitely supports longitudinal monitoring over extended period of time, because that's one of the limitations with an in-lab test or even a one-night home test. Sometimes it doesn't give us consistency related to understanding trends and patterns. Again, as I mentioned, the sleep stage is not perfect, and wake detection accuracy is very weak. Some of the opportunities that exist is that some of the device-to-device variability affects consistency, and user adherence can be very challenging. Sometimes many people don't wear it consistently, so it's sometimes hard to find consistent trends. And again, I've had this in my practice many times. Sometimes it does increase anxiety from some people. I had a person who didn't get deep sleep and was very adamant about, the impacts of that, which was very challenging because I didn't know some of the validity of the device that he had. At what point does consumer data become clinically actionable? So obviously with research right now, a lot of these device companies are taking this data and mining a lot of this data from more people that have access to it, which obviously aids in better accuracy of this. The sensors that are getting more with some EEG signals are becoming more commonplace that I'm seeing around that's giving more good data. And it's really becoming standardizing a lot of this so that we can be able to have truly very consistent data that we can be able to really be able to make clinical decisions, because ultimately what it's doing, it's allowing us to see consistent trends that likely, if we do a traditional study, will probably indicate some of the data that's being coming from these devices. And lastly, they're really looking at specific populations to try to get some more of this data. I've had a lot of companies that I've talked to focusing on from athletes to the military that I think is helpful to be able to aid with some of these AI to be able to get some of these algorithms to be more accurate. So real world applications of sleep wearables. Again, consumers are using these for more sleep self-tracking and improving sleep hygiene. Obviously, some of the researchers that are getting this data are being able to improve their algorithms. And again, for right now, it's definitely a good aid for screening. Again, a more formal test is needed to be able to diagnose conditions. And a lot of these are starting to integrate other measurements to look at the body as a whole, including exercise and nutrition. So challenges ahead. Again, as I mentioned, the sleep staging is the big one. Again, algorithm transparency, being able to understand how it's getting this data and has it been validated, and has it been, validated by our research arm. Another big thing is many people may not be charging their devices, so it doesn't capture the whole night. I know many people that wear certain watches, usually charge them at night, so they don't always use that sleep data. And again, there's some regulatory hurdles related to some of the liabilities and that data, and I think somebody will be talking about that later. And then, of course, some of the patients want to know where their data is going and some of the ethics of being able to share some of that data. Key takeaways, again, look for tracking trends, not for diagnosis. Understand that, again, a more formal test needs to be done if it's in the lab or at home, depending on clinical condition. Again, we need, advocate for metrics that are that measure sensitivity and specificity. And also we need to be able to ensure that, patients understand that, of how the data is being derived, and understanding a little bit about what it means so that they're not misled. So wrapping up, provides great insight. Obviously, we talked about strengths. Being able to monitor trends is very important. Limitations are still being involved in the accuracy of staging and wake detection. And again, the more these devices have all these different sensors and things of that magnitude, I think it's going to improve a lot to be able to be very close, if not as perfect as sometimes the in-lab and some of the home test devices that are out there now. Want to give a couple cases real quick. We can kind of go to the next one for us to kind of consider. Patient presents showing 6 hours of light sleep and 1 hour deep sleep, but feels exhausted. Obviously, again, as we talked about, it's not a diagnostic tool, but again, looking at the trends. And again, we shouldn't base our decision based upon just the data of that device. And I think obviously a more formal test, like a home test or some type of FDA antigraphy device, would be able to be something we can also consider. Next one, a wearable claims at 95% of accuracy in detecting REM. Obviously, again, look at the study, understand again that some of these devices, don't always have the best environments where they're researching it. They could, again, aid in assisting trends, but again, don't use that as a reason to be able to use it as a diagnosis. All right, patient shows mild sleep apnea using an Oura ring, but also shows improved sleep scores after weight loss. Again, consider it as supportive data. Do not discontinue any therapies based upon it. Again, another formal test needs to be encouraged to be able to truly diagnose the condition. But obviously continue with that motivation with the patient so that hopefully that can be a reality. Again, moderate trends over time, make sure that you consider that with symptoms and avoid over-reliance on the consumer data. And again, combine the symptoms with formalized clinical training is basically what I wanted to get out of these scenarios. But ultimately, that's what I've been doing in my practice with many individuals that come in with those types of concerns. And ultimately, I encourage the dialogue that I think helps for us to be able to better manage the patient. These are some references from my studies that from the information from some of the studies that I was talking about today. And thank you very much.
Excellent job, Lyron, condensing a wealth of knowledge into 10 minutes, but we'll have a lot to talk about in the next session. All right. Our next panelist, Henry Weiner, obtained a bachelor's degree in biophysics from the University of Pennsylvania, where he graduated magna cum laude. He holds an MD from Yale University. His internship and residency were at Temple University and his fellowship at Duke. He is board certified in cardiology and in internal medicine and in clinical cardiac electrophysiology. Dr. Weiner is a fellow of the American College of Cardiology and is certified for special competence in cardiac pacing by the North American Society of Pacing and Electrophysiology. His subspecialties are electrophysiology, cardiac pacemakers, and cardiac catheterization. Welcome, Dr. Weiner.
Thank you, Steve. Can you hear me okay?
Sure can.
Cool. I appreciate the invitation to join you all this evening. I think this is a lot of fun, this topic, and in my own practice, I have been, I guess, an early adopter. There's just a lot of data we can get from patients. It can empower patients to participate in their own care. I will be a little broad in my discussion of devices. Not all of these are strictly wearable, but I think they're all clinically useful. So to start, just to remind us of what gold standard wearable remote monitoring of physiologic functions look like, this is the data we get out of an implantable defibrillator. This is a device that's got direct electrical hookups to the atrium and the ventricle, and you can see across the bottom of this slide a calendar with a year's worth of data and very accurate tracking of a variety of relevant, clinically useful parameters that we use in patient monitoring. So for instance, if you look at that second panel, you can see a cluster of non-sustained ventricular tachycardia that occurred about March of 2024. So this is about as good as it gets. It requires little or no patient participation, and it is extremely accurate. Next slide. Oop. Now, moving to more devices that we're discussing this evening, as you know, currently wearable devices can include watches, blood pressure cuffs, and I will also talk a little bit about the Cardia device for rhythm analysis. And you can see that there's a variety of clinical parameters where data can be generated, including heart rhythm, heart rate variability, blood pressure, respiratory rate, and you can read the data. There's potentially a lot of data available to us. Next slide, please. So just to remind us how devices like watches measure heart rate and generate this data, this is a technique called photoplethysmography, where there's a little green laser sensor on the bottom of the device that goes through the skin, reflects into the dermis where you have capillaries, and comes back to a detector. And if you have enough computer power, you can start to generate lots of interesting things. And you can generate basically pulse tracking, and then the device easily can keep track of heart rate. So heart rate variability, detection of irregular heart rhythms, oxygen saturation, we talked about sleep, and there is the hope that we'll be able to measure blood pressure, and that is an area of active research. Next slide, please. In addition to that, many devices allow you to make direct EKG recordings by touching two fingers to poles on the device. This is a Fitbit, and you put your two fingers across the device and you can record an electrocardiogram directly. So in my world, two of the very common things that I'm doing is looking at this kind of data and then looking at heart rate kind of data. And the next few slides will show you from my practice. And I literally pulled these cases within a week. So this is something we do all the time. And we'll illustrate a couple of different use case scenarios. Next slide, please. So here's a patient with postural orthostatic tachycardia. And this is a heart rate trend via her Apple Watch. And you can see between 12 a.m. and 4 a.m. roughly during sleep, the heart rate is low. But as soon as the daylight hours occur and the patient's up and around, the heart rates are increased. And then in the evening, she gets this inexplicable, fairly abrupt increase in her heart rate that is associated with symptoms of lightheadedness and palpitations. And this kind of data in and of itself is not diagnostic, but it's extremely useful in following these patients. Next slide. This is a device that's not technically a wearable. This is a patient I just saw a couple of weeks ago, and you can read he's an older gentleman with hypertension, and his Omron automated blood pressure cuff told him that he had an irregular pulse and that he might be in atrial fibrillation. He spoke with his physician and was directed to go to the emergency room, where he waited 14 hours and then was told, yes, he were indeed in atrial fibrillation. He was given apixaban and referred to us. So it's a good example of how impactful devices can be, but it's also a tale for us as the healthcare professionals to be able to rise to the challenge of managing these people in a more efficient manner. Next slide, please. Here's an example of monitoring for atrial fibrillation with an Apple Watch. This is an older patient with atrial flutter that was ablated in 2019. And the next year, we're able to discontinue his anticoagulation and monitor his rhythms with his Apple Watch. When I saw him back in 2022, he had one episode of atrial fibrillation detected with an hour, and I allowed him to continue off his anticoagulants. But then last year, he came back with 18 hours of atrial fibrillation, and I resumed his Eliquis. So in patients who you understand the rhythm, Apple Watches and certain other devices are FDA approved to monitor for atrial fibrillation. And in the right patient, this can be a very useful approach. Next slide. So here are the FDA cleared wearables for atrial fibrillation detection. And in fact, they are intended for home screening. And these are all patients who should have a medical diagnosis. And then you can follow them with these kind of devices. Next slide, please. A couple of pitfalls here in the next two slides. This is one of them. Our previous speaker has raised, I think, an important point that patients can get kind of fixated and anxious and have behavioral health consequences. This is an example of that. This is a patient with palpitations, and they make recordings every time they feel palpitations with their Cardia device. The Cardia device tells them that they have atrial fibrillation and they think they're going to have a stroke. In fact, these recordings are not atrial fibrillation. They're sinus rhythm with wandering atrial pacemakers. And so there are subtleties in these patient populations that you have to appreciate. And this is an individual who's really had a fair amount of anxiety around the use of this device. Next slide. A couple of billing aspects. You can bill for these things as physiologic remote monitoring, but they are complex. What I generally do is I include at my review of this kind of data in my office note, and it documents for the complexity of the visit just as if you had reviewed an echocardiogram or an electrocardiogram. That's simpler and seems to work fine. Next slide. So the conclusions are these devices are really smart and increasingly ubiquitous. They're useful for monitoring chronic conditions rather than making diagnosis. But in monitoring patients chronically, I find them very, very useful. They do challenge us to think in new ways to manage chronic diseases. And I think we have to learn to kind of practice differently to take advantage of this kind of information. No, yeah, these I don't need. I'm done. Yeah, these are extra.
Okay, thank you very much, Dr. Weiner. Truly
Yeah, these are
appreciate.
all extra here. Thank you.
Okay, great. Interesting perspectives. Our next panelist, Prakash Seshadri, MD, is the Chief of Endocrine at Christiana Care Health Services. Dr. Seshadri completed his fellowship at the University of Pennsylvania, residency at Tulane, and medical school at Upstate Medical School in New York. Dr. Seshadri has extensive experience in osteoporosis and screening, thyroid disorders, diabetes, and glucose monitoring. Welcome, Dr. Seshadri.
There I am. Whoops. There I am. Thank you all for inviting me. Can you hear me okay?
Certainly
Yep.
can.
Okay.
Yep.
Alrighty. Thanks. Okay, we'll go to the next slide. This is somewhat of a busy slide here, but this is these are looking at sensors, specifically at the Dexcom sensor. Dexcom has been around at least since 2006, and you can see how they've progressed. We're at the Dexcom G7 now. I think the most important thing to look at here is the mean absolute relative difference. That is relative to your average point of care measurement at the same time as you're looking at the sensor. What is the difference? And the smaller the number, the closer you are to that reading. The readings from sensors are not the exact same as the point of care blood testing. They're slightly delayed and can be affected by fluid shifts. But they're a good devices to track patterns and follow trends. So since the beginning of the introduction of the Dexcom, the amount of time that they can be on your body has extended. So the Dexcom G7 is now, which I think most people would be wearing if they do choose a Dexcom machine, would be about 10 days. It used to have an additional transmitter device that had to go on top of the sensor, but that's been eliminated and it's just one simple device. The does not need calibration. It measures glucose every 5 minutes, and you can actually share that with family members, especially in in the pediatric population, which is a good thing for younger parents of younger children for them to wear. And as far as interference with substances, from most of my reading, it's vitamin C, ascorbic acid, high doses of that, high doses of Tylenol, 1,000 milligrams every 6 hours and these substances tend to make the sugar levels higher than what you would predict, kind of thing. Next slide. So this is the Abbott company's sensors. These are a bit more popular. The Freestyle Libre 3, unlike the Dexcom, will last for 15 days. It has a pretty good MARD, 7.9%. And actually, this graphic is wrong because what this goes to is the Libre 3, but the 3 Plus is 15 days. No calibration is needed. Multiple more people can be shared with this data. Again, vitamin C, aspirin, and Tylenol can interfere with these sensors, causing higher than normal readings. And next slide. This is the Medtronic sensor, not used very much by itself. It's usually used in conjunction with a pump. It's a little bit bigger than those other devices. The Libre 3 Plus is about the size of a dime, and the Dexcom is about maybe a size of a nickel. And then I want to say this is the Medtronic is maybe about the size of a quarter. Next slide. This is the Senseonics product. This is an implantable sensor. It was initially came out as a 3-month device that had to be surgically implanted and taken out every 3 months. Now it's a year. It's a very superficial incision that's made. But it still needs a transmitter. So the sensor is there and you have to put a transmitter on top of it to transmit to your phone. The advantage of this device compared to the other two is that if you knock this transmitter off, you just slap it back on. The other ones, basically that device is done and you have to put on a new one. So it's after 2 days of wearing the device, if it falls off, you got to put another one on, and then you run out of these things, kind of thing. So that's one of the problems that we see. Next slide. Oh, so before I move on to the mechanical pumps, just one of the things that you may notice from patients that are wearing these devices, many times patients will complain of low blood sugars in the middle of the night. I have all of my patients at least know the basic skills of using point of care testing, capillary blood testing for their blood sugars. Mainly for these either unexplained highs and lows. What I'll find in the middle of the night is people will lay on their sensors, and that bends the catheter, causing a false low. And people will say, "Oh, I didn't feel low, but this thing was going off," kind of thing. So we're moving on to mechanical pumps. These are not electronic devices. So just ignore the Omnipod that's there. That is an electronic device. But the Secure Simplicity delivers insulin boluses in 2-unit increments. So you would be doing, so this is for a patient that's doing basal insulin and doesn't want to deal with electronics, but needs to give bolus insulin throughout the day. So they would wear this every day, take it off, throw it out, and put it on another one. The Vigo has a basal rate, but also you can do boluses, and this comes in different flavors of 20, 40, 20, 30, and 40 units of a basal insulin. And then you can press a button on the side that gives 2 units, 2-unit increments there for boluses. Next slide. Oh boy, this turned out really small. I hope you guys can see some of this. So these are multiple different electronic insulin pumps. Medtronic is kind of the oldest company in the market there. All the pumps that are on the market use an AI algorithm that uses the sensor to base future basal rate changes. So the Medtronic will every 5 minutes, all of these pumps will essentially every 5 minutes will change the basal rate. You can, the problems with some of them versus others is that they're very inflexible. And that is to say, you can't change a whole lot. It's just, okay, well, you've got your algorithm and that's all it's going to do. With the Medtronic pump, you can change the target of how low you want your sugar to go. That would be 100, 110, or 120, which can, create some flexibility there. The tandem pump is another pump we use quite often. These are there you can actually change the basal rate, and it does give you tiny little boluses as well if needed. The Omnipod of these pumps that are displayed here is the only tetherless pump that is today. It doesn't use a catheter at all. It uses all the pump information is either on a receiver or a phone, and the insulin and the mechanics are all in the Omnipod. This is another one where it's pretty well fixed what you're getting once it learns you, and there are different targets that you can set to kind of, make either more strict or more lax your blood sugar control. The newest in the market is the Twist pump. It is it is a very small catheter, but all of it is run out of a phone. It's been FDA approved, but they haven't distributed it everywhere. It is supposed to be one of the more flexible pumps as far as both using AI, but then also using making certain adjustments to fit the patient that's using it. Lastly is the eyelet pump. This is made by a fellow that a PhD scientist whose son developed type 1, and this pump was originally supposed to be a dual chamber pump, because with any insulin pump, basically, in any time that you're using insulin, you're basically controlling an accelerator. If you were driving a car, that's all you had to control it. So you either to slow down, you're backing off on the accelerator. And if you're going faster, you want to, press down harder on the accelerator. So the ideal concept for the eyelet pump was to have both glucagon as your brake and insulin as your accelerator. But they're not very good heat stable glucagon preparations around. So that's why we just have the eyelet pump here. It's completely based on a patient's weight. So the pump learns, your patterns based on your weight. And then for meals, you don't typically, for all of these pumps we'll have patients, if they've already know how to count carbs, match an insulin for whatever grams of carbs, or match insulin for whatever sugar that they have as a correction factor. This pump basically takes away correction factors, and it just gives you insulin based on your weight if it's too high, and then you tell the pump if you're eating a small, medium, or large meal, and that's it. Next slide. So I had a small case here. This is a 30-year-old male physician with type 1 diabetes for 15 years. He comes to the office for improvement in his blood sugars. Currently, his A1C was 9.5, but 5 years ago, he had a lot better control when he had 4 other colleagues. In his practice, now he only has 2. His A1C was 6.7 at the time. He's taking Lantus 20 units at night and doing Novolog with carb counting. He's not testing much due to the demands of his practice, and he's open to new technologies. So, I guess it's an open question here. What wearables could he use? I know we're taking questions from a panel, but essentially, he could use any of these devices. I think he probably would be best served doing a sensor as well as an automated pump. I think it's, so it seemed like the biggest problem for him is time, and that has gotten taken away from him by having less partners in his practice. This way, it's a lot easier. And patients that I find that could get themselves under very good control under multiple dose injection therapy can get pretty darn close to normal A1Cs. We're talking about A1Cs of, less than 6, without very many lows. So, the technology out there is pretty good, as long as you're willing to kind of work with it. And I don't know, Lynn, I don't know if I sent you a slide, one slide, and I don't know if you could pull that up. If not, it's not, I can end right now.
You sent me a slide? Yeah.
I sent it actually I sent it to, as a text, actually in this, in
Oh,
a
in the
chat,
chat?
kind of, yeah, just to you.
Okay, let me stop sharing. And I will pull that up. I do not have it in the chat.
Whoop.
Do you want
Oops.
to display it? You can share your screen if you have it.
Oh, okay.
Mhm.
Let me do that, and then, whoops.
Okay.
Let me see, I'm sorry. Oops.
I found it.
You found it? Okay, good.
I don't know if it's going to.
Not gonna open? Uh-oh, sorry.
Let's try. Let's see. No.
No? Oh, okay. Let's see, share screen. Oh, okay. Sorry.
I'll keep working on it as well.
All right. How about now?
There you go.
You got it. Okay.
Yeah.
So this is a display from a Dexcom glucometer, and you can see they usually they set the targets from 80 to 180, essentially, or 70 to 180. Sorry, 70 being less than 70 being kind of stage 1 hypoglycemia, and basically following the rules of wanting patients to be between 80 and 130 before meals and less than 180 2 hours after meals. You can see on the graph there that the patient wearing this device has some lows at bedtime and some highs around dinner time. So if this patient was doing, say, Lantus in the evening and insulin at breakfast, lunch, dinner, it seems like that they would want, you'd want them to have a little bit less insulin at bedtime to prevent the early morning low sugars, and maybe a little bit more insulin at dinner time to knock down that giant peak that happens around around 7 or 8 o'clock. And I think that's it for me.
Very good. Thank you very much, Dr. Seshadri.
All right.
A remarkable new technology, a little bit overwhelming.
Yeah, sure.
Our final panelist, Kimberly Hoffman, uses her 20+ years of experience to serve as lead counsel in regulatory, government relations, and business matters. Her administrative law experience extends to healthcare, energy, environmental, and transportation cases. She is the only Delaware attorney who has been recognized as a top lawyer by Delaware Today in the areas of transactional real estate, zoning, and healthcare law. She has been recognized as a notable practitioner in Chambers USA since 2007 and leads a Chambers ranked practice group. As partner in the full service of Delaware firm Morris James, Multifaceted Matters, Kimberly handles benefit from her partner's expertise in tax, estates, employment, and family law, and corporate governance. We welcome you, Kimberly Hoffman.
You're still muted. Let's see.
Got it. Just had to find the right button. Thank you, Dr. Kushner, for that introduction. So do not get your hopes up. with the best lawyer's business because in this particular area, there are not that many clear legal answers, as we will see, but I'm going to go over some of the issues with you that wearable devices present for physicians and practices. So in order to do this analysis, I had to sort of come up with my own definition of a wearable to sort of inform what I was going to look at in terms of research, case laws, and statutory schemes. And it pretty much tracks with what the rest of you have been discussing this evening. A device that can be worn or mated with human skin to monitor the individual's activities. But what I want you to note is that I don't have a citation to anything here. And if we had a more thorough regulatory scheme or we had some statutes or some well-developed case law, I would have something to cite to you to say, well, this is legally the definition of what a wearable is. So what I want you to note here is there is not a legal definition of what this is. And so that just sort of contributes to what I think is a really nebulous set of rules around how these devices are employed in your practices, which, considering the use that all of you are putting them to, is a little bit concerning because it's become very important to your patients, to your workflow, to your diagnostic methodologies, but people aren't regulating in this area very much. So as you've all been saying, these have become really important diagnostic tools. This originated more in the wellness space, not so much purely in the medical field, but the amount of clinical data that can be collected on patients, things that are the social determinants of health, and then the ability to share that data with diagnostic services is just something that seems scheduled to grow and become more dominant in a lot of practices as time goes on. So you all have been talking about what you all use this for, everything from heart rate, blood pressure, respiratory rate, oxygen saturation. There's just so many vital signs that can be collected with these wearables. Cardiovascular function, sleep patterns. It's just absolutely incredible what these can do. And then the utilization, what you all are doing with it is just amazing and powerful as a diagnostic tool. So these are all the good things, but as is very common, technology has really gotten ahead of the law in this regard. So what are the different issues that we need to think about given how you all are utilizing these wearables and how your patients are utilizing them? So the first thing to know is there is not a comprehensive regulatory scheme for these things. The FDA does not have specific use recommendations on all of these devices. They don't have a comprehensive sort of code about wearables. I mean, some things are approved for certain uses, but not everything that people are using in diagnosis. The FDA has not spoken on all of those things. And all of this data that these wearable companies are collecting, HIPAA does not necessarily cover that data because they're non-providers. And so it doesn't really become HIPAA covered until it gets sort of fed into your patient's medical record. And then you become responsible for it, right? But your patient may not be aware that all of this data that is being collected by the wearables maker is not protected by HIPAA, and in fact is very often being sold. So if your patient has the impression that you have some kind of control over this body of information, that's not always necessarily going to be true. And that's really different than what's happening in the office when you're taking someone's vital signs and charting and things like that. And so you've got the patient, you've got the physicians, and you've got these wearable companies, and you don't necessarily have any kind of contractual privity or anything like that between all of you that talks about your relationship and who's responsible for what. And so if something goes wrong, like a data leak or a patient is damaged in some way because of the way that this data is inaccurate or utilized improperly, then the level of responsibilities between all these parties is pretty murky. So when you shift over to the medical malpractice realm, obviously the wearable's not a physician, right? So at what point does that patient physician relationship form and somebody takes responsibility for this data? And there's a possibility that the patient can make out some kind of prima facie case for negligence that would lie in malpractice. And what you might think about that, what your insurer thinks about that, and what the patient is thinking is being done with this data or not being done with this data can be a lot of different things. As some of you have alluded to in your presentations, of course, this data is not always complete. It's not always reliable. There are situations where the patient can actually alter the data or just provide incomplete data by maybe not always wearing the wearable. So that's concerning if you're using it for diagnostic purposes. And it brings up a lot of issues as to whether you're able to just rely on this data to make diagnoses, or is there an in-person element, or are there other things that you have to do in order to make sure that you're making an accurate diagnosis, and where the line is with that, it's really not clear. And that just all feeds into what is the standard of care when your patient is utilizing these wearables, you're utilizing the data, and you're trying to make some diagnostic decisions. It's really just not defined. There's not a lot of case law. There's certainly not statutes. There's nothing that I can point you to and say, this is what you have to do and not do in order to meet the standard of care. It's very nebulous out there. So then we have just a whole slew of data privacy concerns, and this would be a concern even if we weren't in the medical realm. This is just a lot of information about somebody, right? And people are signing up for these apps and putting on these devices, I mean, some of which are over the counter, like Fitbits. And they're not really giving a lot of thought to who owns this data and what can be done with it. We don't have the very well-defined regulatory scheme with HIPAA to inform us about what happens if there's a breach and where the responsibility lies for that. And of course, it can also be hacked. So if your patient has the impression that you told them to wear this wearable device and they think maybe you have control of all this data and there's a breach, at least there can be a really serious misunderstanding about who needs to do something about that breach, whose fault that is. And then, of course, there's a lot of state law and federal law developing as we speak about data breaches and those privacy issues that's even, separate and apart from the medical realm. So I told you not to get your hopes up about answers because there aren't that many, but I think that these are the issues that you have to think about as you move forward with some of these really exciting devices, which have tremendous diagnostic potential, which are already, you guys are off to the races using it. But I think that the law is taking a lot of time to catch up with you. So what is it that you can do, given all of these big question marks, to protect yourself, to inform your patients, and to hopefully get to a point where you have a better diagnostic environment, patient relationship, and you can safeguard against, at best, misunderstandings, and at worst, some serious problems with health outcomes? Well, one of them would certainly be disclosure. Since you don't control this data, you don't control what the wearable companies are doing with it, informing your patients that that's the case, maybe informing them that you don't monitor this all the time, right? Like, what are you actually using it for? If there are people who think that you're like sitting around 24/7 watching this data stream come in and making diagnostic decisions, it would probably be better if they understood that that's not what you're doing at all. And so that way, it really reduces the possibility that someone is going to think right off the bat, well, my doctor is responsible for what happens with this big body of data, that the wearables company might be the one who's controlling that. So telling people what's going on, I think, is always better than waiting till something bad happens and realizing they didn't understand. So just think about possibly working that into some of your patient disclosures and acknowledgments. Another possibility is if there are wearables companies that you do a lot of work with, think about getting business associate agreements with them so that you actually have a comprehensive agreement about what they are doing with this data. Maybe you want to try to get them to promise you that they're not going to actually sell all of your patients' data, or at least that you understand what it is that they are doing with it, and that you have an agreement about what would happen if there was a data breach and who's responsible for that. Because in all likelihood, you want to put that responsibility on them, because you're not really in a position to safeguard this data unless it hits your patient's health record and you're storing it there. Then if you have some protocols for situations where you see something in the data and you have to have a follow-up as opposed to just making diagnostic decisions based on the data, I think those protocols are you're going to have to develop them yourself because there's not that much guidance out there, but I think that's an important thing to do, and to have an understanding with the other folks you practice with about how what it's okay to do just based on the data, when you need patients to come in. And this is something you're probably walking and talking and breathing, already, but maybe think about committing it to internal practice policy so that things are consistent across the different practitioners in your group. And then just think about, with all of these different wearables and all of this data, what are the pitfalls with some of the data reliability? Is there anything you can do about that? Is there any kind of gap filler device or test or something else that you could bolster things up with? And then, go back to the disclosure. Is that something that you should be telling your patients in a written statement that they sign? Look, this data is helpful, but it's not everything. And, we need to see you every month or whatever it is, just to make sure that we're matching up with what's happening in person with what we're seeing in the data from these wearables. So those are my suggestions for dealing with what I consider to be a big regulatory gap with regard to wearables and how the law handles this data and how you use it diagnostically. And I'm happy to answer any questions during the panel discussion.
Thank you, Kim. Excellent, quick presentation. Okay, well, thank you all our panelists for these presentations. We'll open the floor for questions. Lynn, do we have any questions?
Yes, we do. I am going to quickly assemble our panel so that they're together. It will only take me a quick second to do that. And we do have, if you have any questions, if you could put them in the chat box for us or raise your hand, the panel will be, we're almost there. There we go. All right, we have our panel up together, and I did see some questions in the chat. Dr. Shaw asked, even the 1 year long one that is implantable and under the skin. Dr. Shaw, are you with us? Can you open your mic? And I'm not sure with whom. I know that was, can you clarify your question for us? Is Dr. Shaw still with us?
Yes, I'm still here.
Great.
But I think he might be answering my question.
Yeah, no, I think, yeah. So I'm not really, I'm not altogether certain about the coverage on that. We've not really, I think maybe only 2 patients in our practice of thousands that have actually gotten this done. So I can't elaborate who's paying for that, because it's a dual pay. It's actually to have to pay for the procedure to put the thing in, and then the actual device too. So
Yes, as a family medicine doctor below the canal, I take care of a lot of diabetes, and I've had 2 patients inquire about this, and I'm like, I don't know if I refer you to. I talk to them about insurance that I'm not sure, but then I'm like, I don't know if I refer you to endo or to surgery. So I was just interested in knowing.
Oh, okay, yeah, yeah. You know, our former partner, Rapu Hundal, actually does these, and I think he did do these for our for the 2 patients that requested it. And so he did. A non-surgeon can do this, so it's free advertising for him. But he's the only one I know that does them. So
Great, thank you.
I'll throw out a question. And, you know, in primary care, we have many of our obese patients are wanting to try the injectable medications to help them lose weight. And the insurance companies are telling us, geez, we want to know, and they're getting really sticklers about this. Do they have a gym membership? How much, you know, how many steps are they doing per day and different things like that. But one thing also is, of course, sleep apnea plays into this as well. So, Lyron, I would say, could we use, and will your wearable be a possible entry for consideration for the insurance companies to cover one of these medications? What do you think about that?
Are you asking me directly about a wearable for insurance to cover?
As an additional piece of information that might help get my patient that medication.
Oh, yeah, I think a formal test, definitely. We're seeing a lot of patients that have moderate sleep apnea, typically in a BMI greater than 30. Most plans are covering medications to help with the weight loss.
Yeah, but I can't just say, well, if his watch says this, that you know that he's having an episode.
No, you need a formal test for that
Nice
to
try
be.
there, huh? All right, thank you.
But
Dr.
I
Shaw
also,
has her hand open
yes,
up.
I just
Go right
wanted to make sure that it has to be moderate to severe sleep apnea. Mild does not count. And right
Correct.
now, the wearables do not well, they're not diagnostic, first of all, but then they won't even give a stage. So insurance companies will not accept that as it's not a diagnosis. And then you need to actually show this the sleep test and show proof of that, moderate to severe.
Correct. Some of the things that are also misleading is some of these wearables that I talked about. Some of the studies that we actually conduct look like some of the wearables, but they're actually FDA approved. So obviously, if they use an FDA approved device that can diagnose sleep apnea, then obviously that report would be suffice.
I'll throw another question out there. Kim, my colleagues have said, what happens when the patient comes into the office and says, you know, I was wearing my watch and it says that I have atrial fibrillation and you know, it's a busy visit. You're handling a million problems and you excuse them and you say, well, you know, you can't always believe those watches. And they go home and of course they have a stroke and but I told my doctor in the office that I had atrial fibrillation. Look, I tried to show him this. And so, well, that's another worry. I have concerns, as my colleagues do, that that is now entered into our private office space. And what are we to do about something like that? Henry, please chime in.
You better look at the watch.
Steve, my opinion is that you have to take those kind of comments seriously. And if someone walks into your office with that complaint, that essentially guarantees them a 2-week Zio patch medical grade recorder to start with. So yes, take those kind of comments seriously.
Yeah, I mean, remember in my presentation where I had the graphic of the black hole? So that was meant to demonstrate the fact that there's just a big black hole in how standard of care is really to be defined in that situation. But I would just analogize it to any situation where a patient comes in and tells you something, and it's the same thing in law. Like some of it we have to filter out and realize there may be mistaken or it's not important. And, then sometimes you turn out to be wrong about that. So it's a definite break. And the question is it more, and this is, I guess, where the evolution in the courts and the statutes will go, is it more reliable, quote unquote, because it is this data that was collected by a device versus an impression that your patient has about their own health? And I have no answer to that. I'm sorry.
I'll give you an example of something. So I had a patient the other day who has a CPAP device that basically, from my interpretation, and the device's information that we get in a secured portal that clinicians can access, gives us information on the data. Well, this person goes to a Reddit board, and some guy has a third-party thing where they can take that chip out of their device, put it in there, and now he's trying to tell me what this device is basically having with metrics and stuff that he shouldn't have access to. And he's basically telling me that his condition is getting worse and he's getting more anxious because of this data that this, again, third-party guy developed for people to be able to take their chips and get information. And obviously now I have to try to manage that. And even though from an objective standpoint, and even the data that we got from the manufacturer's own portal, I had to really do more effort in educating him. So even though technically it's not a wearable, but again, it's using information that I think is not something that's been validated. But unfortunately, as clinicians, when you have patients that sometimes, get more involved in things that they're not educated on, it kind of puts us at a little bit of a risk.
Dr.
I think-
Biasacco. Oh, I'm
Yeah.
sorry, Commissioner.
Yeah, I'd like to ask him a question. The future looks like AI is going to be playing a big part of our medical careers in the future. I'll probably be gone by that time, but it will be playing a pretty big part in things. And we're all worried about, okay, if AI is going to make a decision and help us make a decision, I make the decision is wrong because the algorithm was wrong. Who's responsible? Is it the doctor? Is it the doctor, or is it the guys that made the AI technology? I mean, that's going to be a critical issue, I think, in the future.
Yeah, can I hold up that black hole again?
You lawyers better lawyer up right now, I'll tell you.
Well, but the thing about it is, you can't, I think people are going to start treating AI and these chatbots like they're doctors. So it's not as bad that they're already going on, WebMD and self-diagnosing and taking all this data that they don't know how to interpret. But I mean, I'll just tell you in the legal realm, first of all, we're not using AI for legal work because we have client privacy concerns with feeding our work product into the language learning model. And I think that that's something that physicians are going to have to think about that too. Like, can you really take this patient's data and stick it into this model, at least not without some kind of waiver from your client? And then the problem we're having in law is it's hallucinating a lot of things that are just completely la and like false and makes whatever. So even if people start using it a lot, how are you going to have that quality control to get rid of the hallucination? Or are people going to take shortcuts and just look at, well, AI told me to cut or give someone this pill, and you're going to have these younger people who are like used to that kind of thing, and I don't want to be responsible for it. So again, back to the black hole right there.
I just came from
Thank you.
I just came from the health conference in Vegas. I don't know if anybody's familiar with that conference, but it basically is all about technology and medical practices. And the stuff that was there will blow everybody's mind about AI and some of the advances that I didn't even think were possible. But they had avatar doctors that you could talk to, and they would basically try to condition. There was a person who had an app that could say, they said it was FDA approved. And again, I didn't validate it because I just saw it. But from a picture of your face could give you your blood pressure, your pulse, your oxygen, and everything. It's crazy. It was the stuff that was there. I just was blown away.
May I ask a question, Dr. Kushner?
Absolutely.
Thank you. This is for Dr. Seshadri. Do you see a future where metabolic wearables could help actually prevent diabetes or obesity and not just manage them?
Yeah, I think it's that's definitely a possibility. I mean, if somebody had pre-diabetes or had a lot of the factors or history, family history of diabetes, I could see that. There are two commercially available over-the-counter wearable sensors. And so, I mean, the first thing that gets knocked out in diabetes is kind of what's called the first phase insulin spike. And you'd be able to see that with sugars rising, it should be a relatively flat hump that you see. Instead, you would see a big spike, and that might get you to lose weight, or change your diet, or do more exercise after meals, things like that. So yeah, definitely.
Thank you.
Any
I don't
further
see.
questions? We good, Len? Any
Yes.
further questions? All right, well then this concludes our CME presentation this evening. We hope you enjoyed the program and found it to be informative and inspiring. It certainly has for me. A special thank you to our keynote speaker, Professor Martha Hall, and to our panelists, Lyron Deputy, Dr. Henry Weiner, Dr. Prakash Seshadri, and Kimberly Hoffman for sharing your experiences and valuable insights with us tonight. I'd also like to thank Lynn Robinson, Anjay Arnold, and Dr. Matt Burdett for helping put this excellent conference together. We really appreciate your efforts. And just a reminder, our MSD annual meeting week continues this Saturday morning at 8 a.m. at the Christiana Hilton in Newark with an exciting presentation by Stephen Klasko, former president and CEO of Thomas Jefferson University and Jefferson Health, who will present on Swifties, startups, and the singularity, followed by the MSD's council meeting. Registration has closed, but if you forgot to register and still want to attend, call Mary LaJudas. She will get you in. You will receive an email following the sessions with instructions to claim your CME credit. Thanks, everybody. Have a wonderful evening. If I don't see you all, have wonderful holidays coming up. Enjoy your
Thank you.
night.
Take
Appreciate
care.
it,
Good night.
guys.
Thanks,
Thank
everyone.
you.
Thank you.
Bye,
Thank you.
everybody. Bye.
Bye.